Welcome to Charlottesville and this Commonwealth of Virginia Medical Analytics Summit hosted by the University of Virginia and its partnership with the MITRE Corporation. This is a follow-on from a summit that we held at MITRE in Baltimore last spring, and it continues the drumbeat of the partnership towards shared analytics to improve patient care and safety. My name's Randall Moorman. I'm a clinical cardiologist. I've been here for more than 25 years. Tomorrow, you'll hear about what my group and I have been up to in the way of developing predictive monitoring analytics. For now, you need to know I'm the Chief Medical Officer of a Charlottesville startup, Advanced Medical Predictive Devices, Diagnostics, and Displays, or AMPD. Let me make a few remarks about the nature of this summit. So we all hear the cry for better care, better health, and lower costs, and we are all aware of the rapidly escalating ability to perform numerical calculations on computing systems. In some way, pitting computers against healthcare problems is one of the focuses of this summit. We're here to talk among ourselves about the next steps in that evolution. Now, from the standpoint of a bedside clinician like myself, that evolution has been from note cards and flow sheets that we filled out by hand to computerized plots of those values in the electronic health record, to early warning scores, to the Rothman Index and eCart, and to the COMET score that you'll be seeing demoed this afternoon. So we've evolved from doodles to better visualizations of our doodles, to simple rules, to smarter rules, and finally to continuous assessments and estimates of patients' risks and trajectories. From the standpoint of the hospital CIO organization, I dare say that the evolution has been toward improved means for achieving technology visions in networked healthcare information systems. And we're all aware how PCs have turned into Hadoop and Spark nodes, how hard drives have turned into the cloud, how Explorer and Finder have turned into HDFS, how Excel graphics have turned into Tableau, how Fortran has turned into Python, and how everything and anything has turned into the Internet of Things. It seems now that the only limitations to what can be analyzed and reported in a healthcare institution is the imagination of the leadership and the regulators. So we're incessantly at inflection points in these evolutions, and I hope that this summit marks yet another one of those. We're not here just to keep current with this, we're here to move ahead. We're here to talk about frameworks for new ideas, for improving analytics and developing new ones, and most importantly, how to share them and to lead the nation in improving patient care and safety through their use. Now this leads me to introduce our first speaker, Rick Shannon. He's my boss. He's the boss of a lot of us out here. He's the Executive Vice President for Health Affairs at the University of Virginia. Rick is a clinical cardiologist who was educated at Princeton and the University of Connecticut, trained in internal medicine at the Beth Israel Hospital, was one of Gene Brownwald's chief residents, and trained in cardiology at the Massachusetts General Hospital. Before coming here a few years ago, he was chairman of the Department of Internal Medicine at the University of Pennsylvania. Rick is an intergalactic eminence in patient safety and quality, and since coming here, he has injected this place with a zeal and a fervor not common since Jefferson. So Rick, welcome, and those young people in the audience, take notes when you introduce your boss. That's how it's done.
Thank you, Randall, for that kind introduction. Although such comparisons really are quite embarrassing to me. I guess intergalactic means you can expect me to be a little spacey in my comments. But thank you, and thanks to all of you for joining us here today. On behalf of the University of Virginia, we're extremely pleased to co-host this event with our partners at MITRE. I want to set the stage by perhaps spending a few minutes sharing with you my ideas about where the journey toward healthcare transformation is and why the bringing together of the partners in this room is so essential, I think, to advancing the much-needed transformation in the U.S. healthcare system. The first thing I'd like to begin by sharing with you is the fact that while it's often cast in political terms, the need for transformation of the healthcare system in the United States is not political. It plays out in the theater of politics, but it is of its essence not political. It is demographic and epidemiologic. The forces that are causing the nation's healthcare system to modify its approach are embedded first in the changing face of human disease. The fact that chronic conditions now lay a level of complexity and cost on the U.S. healthcare system that has been unforeseen. The epidemic of diabetes alone over the next 25 years is in and of itself expected to cost more than the nation spends on all healthcare today. More than $4 trillion is expected to be consumed at the current rate of disease prevalence of diabetes within the next 20 years. We spend $3 trillion on the whole system today. So that's simply an example of a chronic condition in its evolution, if unchecked, has the real risk of threatening one of the biggest economic drivers of the nation's sustenance. The second thing I would point out is the demographic, which we're all aware of, which is the coming of the baby boomers into the nation's Medicare program. Today, 10,000 Americans turn 65, and they will again 10,000 more tomorrow and 10,000 more the day after. And every day for the next 15 years, 10,000 baby boomers will enter Medicare. By 2025, there'll be 90 million Americans on the Medicare rolls. Today, there are 46 million Americans. So in a mere 10 years, a doubling of the number of Medicare beneficiaries. And we all know that the nation's ability to honor the promise to American seniors is threatened by the rising incremental per capita costs for each Medicare beneficiary. So while transformation of the healthcare system plays out in political circles, it is of its essence demographic and epidemiologic. And therefore, in many ways, those forces are extremely difficult to alter. And if you consider the narrow time frame in which they must be altered, the problem is, I think, truly daunting and often underestimated. So what's the consequence of a failure to get our hands around these important forces? Well, I think we all recognize that even today, the rising cost of healthcare is having a profound impact on the wages of middle-class workers. The equation is quite simple. For every dollar increase in healthcare premiums an employer pays, it functionally suppresses the wages of the workforce by about 84 cents. So the erosion of the American middle class, while often blamed on education and recession, actually has its origins, certainly the stagnation of its wages, in the rising cost of healthcare. An employer has two choices. One, they can pay for your benefits or they can pay for your increasing wages, but they often can't do both. So that is one immediate example of what has happened over the last 10 years as a result of the unchecked costs of healthcare. But beyond that, by the year 2029, the nation will spend all of its revenue on just 4 programs: Medicare, Medicaid, Social Security, and the federal debt. So by 2029, due to that baby boomer escalation, all 4 federal programs, Medicare, Medicaid, Social Security, and the debt, will account for the entire revenue of the United States government. That means no money for defense, no money for education, no money for the environment, unless one of 2 things happens. We substantially raise taxes or we borrow more money. And those are the fundamental economic drivers of the need for healthcare transformation. Now, I will tell you, in its earliest days, healthcare transformation has been inadequately informed by the knowledge, skills, and mindsets of people in this room. It has rather been informed by a relatively singular focus on payment reform. So while Randall mentioned the triple aim of better clinical outcomes, better service, that would lead to lower costs, That's the equation. Unfortunately, the focus has been on lowering the cost without due consideration to process improvements to lead to better outcomes. And that's because the lever government has most easiest to use is lowering payments. I consider population health perhaps one of the most commonly employed terms in conjunction with healthcare transformation to be a euphemism for lowering cost. In fact, most of the efforts in population health have been to push risk to providers using small carrots and big sticks. So virtually all of Medicare's payment methodologies are about small carrots and big sticks, about cutting payments to providers and cutting services to patients, all in an effort to lower cost. What we're here to talk about today is how can innovation and technology improve process outcomes so that we deliver the right care to the right patient at the right time, the first time, no defect, no error, no waste. And if we achieve the right outcome the first time, no defect, no error, no waste, we lower the costs in the system that are consumed in things that simply add no value. But to do this rapidly, we in healthcare providers need new partners. We have to take a different approach. This is a real challenge because, as Randall mentioned, organizations such as UVA have their origins in these very tradition-rich approaches to how care is delivered, often immovable in terms of the ability to adapt. And we are not alone in that. I think most healthcare delivery systems are steeped in tradition and really eschew the idea of fundamental transformation. So as a consequence, for us at UVA, and I think for the general healthcare community as a whole, we need to find new partners if we are going to transform that delivery system. And in fact, that is what the UVA-MITRE partnership is all about. MITRE has been involved in solving vexing, complex national problems through technological solutions for more than a generation. That's what they do. And what we're doing is simply opening the doors of the University of Virginia Health System as a learning laboratory for MITRE to test technological innovations that then can be rapidly shared in partnership with everyone in this room and beyond. So proof of concept testing rapidly shared. So today, what we're asking all of you to do is to join in that shared purpose of transforming the delivery of healthcare through innovation based upon technology. And to co-create with MITRE and UVA and each of your organizations these platforms. No one owns this. This is partnership. It must involve shared purpose and co-creation. Very different than the way healthcare organizations have functioned historically. Now, there's no question that modern healthcare is awash in big data. Again, second only to population health and used in the vernacular today. We know about systems biology, the complex interaction of multiple physiologic and pharmacologic systems within the body. We know about the evolution occurring in genomics. The electronic medical record. Each of us has spent hundreds of millions of dollars in building these enterprises, but yielding very little, if any, meaningful information. We have been unable to fully harness the power of the electronic medical record, perhaps because we've imposed it on sick, unstable systems. And then, of course, there's the issue of claims data, the financial pieces of this, all large pieces of information that have very little, if any, interaction. We need we need to evolve from when I grew up, which is where we were measured by our IQ, right? Remember your IQ, your individual intelligence. Now moving through a period where we're measured by our digital intelligence, to a day where we're measured by our artificial intelligence, to a moment where human beings learn together with machine learning, where cognitive computing becomes the ally of the provider. This requires new ways to sense, to amplify, to predict, and to intervene, all of which have their basis in some of the technological innovations about which we'll hear today. But this can't be done by a single system alone. This requires all of us in Virginia and well beyond the Commonwealth to come together in the pursuit. Finally, I want to say that if we are to do this, we must focus on a few early opportunities to harness the capability of technological innovation for the betterment of the human condition. We cannot be 1,000 points of light. We must come together in a focused way, working with partners like MITRE as delivery systems on a few key things. And what we've started to focus on, and which is subject to conversation today, would be harnessing the power of the electronic medical record to develop better predictive analytics. How powerful would it be if you could know today what was going to happen to your patient this afternoon and interdict in a meaningful, early, and focused way? We need to be able to create the ability to hover. By that I mean the future will be that an individual with diabetes and hypertension and hypercholesterolemia will visit the provider, which may or may not be a doctor, one time a year for a complete comprehensive evaluation. And the rest of the care would be provided remotely through sensing, digital equipment in the home, constant feedback of physiologic information to providers, and interventions done remotely. Every American, a single visit to the doctor, all other care provided remotely for the management of chronic conditions. Think of the power of that opportunity. Is it doable? As we discussed last night at dinner, we can measure tons of physiologic information in astronauts in the space station. How is it we can't measure physiologic information in the confines of Charlottesville? These are all possibilities. And then finally, I think as we begin to exchange data, there will be the challenge of securing the data. And I think most of us in healthcare, those of us that are not technologically privileged, like many in the room, have grown up thinking of data security in healthcare as being HIPAA compliant. It's laughable, right? When you think about the opportunities today for data to be basically taken from the health system through sophisticated hackers. If we are going to be successful as a community in sharing data, we've got to figure out better ways to protect it. So when you think about predictive analytics, hovering to gather physiologic information, and protecting data, you can find no better partner than MITRE. So I think those of us that are in the provider community should be privileged today to be sitting in a room with these partners who are here committed with us to this transformation. So I look forward to the conversation over the course of the morning. We appreciate all of you taking time to join us, and let this then mark one of those inflection points where we develop the resolve as the provider community to really transform healthcare through innovation and technology. Thank you.